Good morning, Chair. Good morning, AIOS. My controversy, refractive happiness after cataract surgery, emmetropia, multifocals, monovisions, or a minor cylinder 90 degrees. I do not have any financial interest in this presentation. When we have so many tools to achieve our goals today, and of course the basis is biometry, and in our search for accurate biometry, we have upgraded technology and adopted it to the maximum. We have revised formulas taking virtually everything into account, and yet the expected lens position of every eye has been elusive, and a plus minus 0.5 error is expected in the predicted IOL power. So it is common practice that we add plus 0.5 to one diopter sphere to the suggested IOL power for emmetropia, so that even if our patients are not emmetropic, they should not become hypermetropic, requiring glasses both for near and distance, even if they become a little myopic. This is a standard practice, and we practice low myopia for virtual spectacle freedom, because in absence of disease, a minus 0.5 sphere can actually give us 20-30 uncorrected for distance, and the patients can read N5 with a pupil size of 2.5 millimeters. Myopic astigmatism as multifocality has been a common practice in the ECC-PCI era, and there's been a lot of reports to support that. A cylinder of about minus 1.25 to 1.5 diopter sphere 90 is a desired post-operative refractive goal. This can simply be achieved by good biometry and adjusting the incision in some cases for virtually most of our patients. But the diffusion that occurs both for near and distance is a compromise for spectacle freedom, agreed for myopic astigmatism, but the same diffraction and the same compromise would be inevitable in multifocal lenses, which shows up in diffraction, defocus, and with photopic symptoms. The patients are already astigmatic, let us remember, on whom we are practicing myopic astigmatism as a goal, and are used to deal with this diffusion throughout their life. The small pupil size and increased depth of focus after pseudophakia may actually enhance their spectacle freedom. However, even if this diffusion causes problems, we can always revert it by using a spectacle and not requiring an IOL exchange, as would be in the case of multifocal IOLs. Let us see the prevalence of corneal astigmatism prior to cataract surgery, when virtually 28% would be no cylinder patients on whom we can practice low myopia, monovision, accommodative, or multifocal lenses. The next group of another 38% patients would be myopic astigmatism, could be used for virtual spectacle freedom, or a multifocal toric IOL. For the next group of another 30% patients between 1 to 2 diopter cell, which is usually ATR, we can reduce it by giving a temporal incision and go ahead with myopic astigmatism as our goal, or give a multifocal toric. The next group of about 4.5% patients with 2 to 2 diopter cell would be corrected with toric IOLs very nicely, and we have toric multifocals in that range. Above 2.5 diopter cell, I think toric IOLs gives wonderful results, and it can be done in the fellow eye with good satisfaction, where he is inconvenienced in the operated eye previously with minus 2 diopter cell. So the biggest problem of pseudophakia, of course, is acquired presbyopia, and any solution is a compromise, a purchase that we do for distant vision to get unaided near vision. Here is my friend Ramamurthy, and I really envy him, who can read without glasses at 56. I've seen him everywhere. And he is blessed with minus 0.5 speed. So he enjoys a very good concept, the concept of monovision. Well, the concept of monovision is here the distant dominant eye identified by the hole in the card test, which is usually the right eye in a right-handed person, is targeted for emmetropia for distance, and the other eye is made myopic to the order of 1 to 1.5 diopters. The problems of stereopsis, which is often anticipated, is not complained much in these studies, since the difference is only minus 1.5 sphere. The problems of loss of contrast sensitivity, restriction of visual fields are not significant in these studies. First, the distant dominant eye is made emmetropic, and this is a good practice for distance, and then a contact lens trial can be given in real life situations for the patients to choose before they can go for monovision in the other eye. Asthenopia rather is a more frequently complained and can be overcome by using spectacles during prolonged reading or driving. Well, this is a wonderful comparison, a head-to-head randomized controlled multifocal intraocular lens versus the monovision study in mood fields, where they say and conclude that the diffractive multifocals were more likely to be spectacle independent, but were more likely to undergo IOL exchange compared to the monovision group. So here is the wonderful world of multifocals, but this is a high demand area and extreme caution should be used to select the right patients. Rather, I would say they should buy into a multifocal lens rather than reselling it for them. So we started with the refractive multifocals, moved on to the diffractive multifocals. We have the +4 hat, and then we have the +3 hat, and now the 2.5 hat. All this probably suggests that we are not actually there, and the trade-off is not very conclusively in our favor. So let us really explore the real world of this photoxia, which has been the main problem of these multifocal lenses. This recently published review suggests that 76 eyes who were dissatisfied with multifocal IOLs, the photopic phenomenon were reported only in 38% of eyes. So most eyes had correctable factors beyond multifocal design, residual refractive errors, wavefront anomalies, decentration of IOL, and posterior capsule opacification and dry eye disease. So we need to choose our patients carefully. To summarize, I would say spectacle freedom is not a myth that our patients want because they have put an intraocular lens in the eye, but the reality is that most of our practices deliver low myopia or myopic astigmatism, giving spectacle freedom with the small size of our population, pupil size of our population. Toric IOLs gives excellent satisfaction for astigmatism greater than 2 diopters.
Thank you, Debasish. Let's open to discussion.
And multifocals should be carefully chosen.
We have a minute.
Thank you, sir.